Just by way of background, my interest in this goes back quite a few years. I'm a public health doctor by training. I worked in the UK public health system for 20 odd years and then started doing more work on national and international events. But most recently I've been involved, as Richard said, with the IHR Review Committee. I was also involved as strategy advisor to David Nabarro as part of the global Ebola response. And I've done quite a lot of work with WHO on MERS outbreaks in Saudi Arabia and South Korea. And as part of that, I've been involved with the global health security and the global health security agenda for some time. So it all comes together in some way. I only have half a dozen or so slides just to set out some of the key things which I think will be useful for us to talk about during this seminar. So I'll go through those and then we'll have hopefully lots of time to discuss. But essentially the presentation is about what is health surveillance and why do we need it? If we need it, what sort of systems do we have? Linking that into the international health regulations, because as Richard said, that is a good framework against which to look at what needs to be done. And then there's some discussion particularly about the future, what opportunities there are, and how this links into health system strengthening in general. So what is public health surveillance? Essentially, it's a means of trying to quantify the burden of disease in a community, in a country, in a population, or in a specific location. It's about measuring the amount of disease there is, also looking at how that might be changing over time. And that's important because what it does is allow us to understand, if you like, what is normal, what happens all the time, and what is abnormal when something different has happened. It also allows us to look at changes over time, so that we can look to see whether interventions that we put in place are being effective, whether we can target interventions more effectively to specific communities or populations, and to identify the unexpected public health events that we see, such as Zika, Ebola, yellow fever, MERS, a whole range of things that have been happening recently. And the intention is to alert people so we can take action early. And obviously one of the key lessons from Ebola was around the fact that collectively the world didn't respond as rapidly as it could have done, and if it had done it more rapidly, we would have seen substantially fewer deaths and illness in Africa than we did do. But it's also key to remember that this is not just about communicable disease. That was the foundation for a lot of public health surveillance systems, but actually once you have them, you can use them for other things. And one of the interesting things, for example, with Zika, is that we don't yet understand what Zika may or may not have been doing in Africa for 50 odd years, but when it got to South America and to Brazil in particular, because they had systems which could link across from infectious disease surveillance into congenital malformation registers and maternal neonatal surveillance systems, they were able to start to make the connection between the Zika and the microcephaly. We don't really know at present whether Zika causes microcephaly in Africa. It is possible that it does, but there simply isn't good enough linkages between surveillance systems to have picked that up. I think that's unlikely, but it's possible. So it's about remembering that these systems cut across into other areas. Traditionally, for example, in the UK, we do a lot of disease surveillance around HIV and AIDS, but that then links across the whole sexual health agenda, but how we do preventive work and other aspects of that. So the main focus has been on infectious disease. That's where the main driver in global health security is, but it does actually provide you with a resource for other public health needs as well. So if we look at what sort of systems we have available, we broadly talk about two categories: the health facility-based surveillance and event-based surveillance. Health facility surveillance is essentially using data that we already collect for other reasons. So if you think, across a network of primary and community health workers, across a hospital system, each time a patient comes forward or somebody wants to be seen or treated, the doctor records the patient so that they have basic information about the age, date of birth, sex, etc. And the health worker would usually also record what the patient complained of and what the diagnosis was and what the treatment was. All that's done because the facility needs to record that for its own purposes, whether that's simply for keeping track of patients, occasionally because they have to send bills in a paying health system. But that information sits there and it can be taken out and used for public health surveillance. And that's the easiest way that we have of doing surveillance, because the effort already has to go in to producing the information. The extra bit is getting it out of the hospital system or the community system into a public health system to look at. And that exists fairly broadly across the world at different levels. It is more sophisticated where there are more resources, but the basic system of recording the people who come to your health facility is fairly common across the world and can be used for this sort of information. And it has the advantage that surveillance has to be there all the time. You can't just put it in place when you see something like Ebola happening. If you haven't got the basic infrastructure in place, you won't do it in time to manage an outbreak. So having this health facility-based surveillance gives you a good background. And that's really about monitoring what happens normally. It tells you what the normal expectation of disease in a country is, or a locality, and therefore you can look to see when that changes. The other key bit of surveillance is what's called event-based. So it's when something happens, how does it come to our attention? And that can happen through the health-based surveillance. Somebody will say, look, we've suddenly had many more cases of this disease than we would normally expect, and that information somehow gets through the health system for people to look at and do something about. But it can also be that people report it through social media. It can be people reported through different reporting systems like the UN system. And what event-based surveillance tries to do is to look at a whole range of areas where information might arise and try to capture from that things that are important for public health. So there are global systems, for example, one called GFIN, Global Public Health Information Network. There's one called ProMed, which is run by the Infectious Disease Service, which are essentially computer-based systems that sit 24 hours a day and they scan social media, they scan Google, they scan media reports, online newspapers, online television, looking for things that might signal something that's relevant to public health. So it might be simply a report from an outpost in Australia about an unusual disease in plants that might become an issue for animals or human health. It's posted online, people can look at it, analyze it, and respond to it. And some of the early information about Ebola, for example, appeared on there at about the same speed it took to get through the WHO systems as well. Event-based systems are important because they allow communities who are affected by a sudden event to find a way to get that information out to the rest of the population, either nationally or internationally, to look for support and help. So event-based surveillance then is about finding abnormal things. The formal system that exists is the International Health Regulation, which I know a lot of people will know about, but I just want to go through briefly some of the key facts about international health regulations, because they form the framework for disease surveillance around the world. They also establish a framework for response, but they put in place legal requirements for the capacities that countries ought to have in their public health system. And one of the challenges that came out very visibly with Ebola is that although we've spent a lot of money on health system strengthening, we haven't focused that money on public health systems and disease surveillance systems and IHR capacity. And that was one of the weaknesses in West Africa. So the IHRs are a legally binding agreement between the 194 member states of WHO. They're not a treaty, they're an agreement. It's an important difference. A treaty is something countries opt into, an agreement you have to opt out of. So once WHO adopted the IHRs in their new version in 2005, all 194 states were legally bound to implement them unless they formally opted out. And no country formally opted out. A few countries had reservations, of which the most significant is the United States of America. And their main reservation is that because they have a federal system, the federal government can't guarantee what the states will do, and the responsibility for IHR is at a states level, so they had a reservation. So it's a legally binding agreement across all 194 member states. It goes back to the 1950s, ship sanitation regulations, which are brought in to help stop infectious diseases, primarily cholera, yellow fever, and things coming through on international transport. But they've been updated recently, particularly after 2003 with SARS, where they were found wanting, so the new version came out in 2005. The new version also moves away from having a small list of diseases, smallpox, yellow fever, which you had to report, to saying actually you have to report anything that might be of public health significance, and it moved away from just infectious diseases to be all hazards. So it does include chemical, biological, and radiological threats as well as infectious disease. And it does include deliberate events as well as naturally occurring events. Importantly, the IHRs were agreed in coordination with the Travel and Trade Organization, so that the international IATA, the International Air Transport Authority, the World Trade Organization, because part of the response to things happening through the IHRs is potentially to put in restrictions on travel and trade and movement. And it was important that we had the right balance between not being overcautious and therefore interfering with travel and trade to ensure public health safety, and not being too laid back and allowing things to happen because we didn't want to interfere with trade, but then things got out of hand, and you can think of some examples of that problem. So it is a balance between what we do for public health safety and what we do to not restrict travel and trade. IHR sets out some core capacities, which all, for acronym MS is member states for those who don't live in the WHO world. All member states have to have certain core capacities. The core capacities are essentially about setting out the minimum public health capacity you need to do public health surveillance, including epidemiology, laboratory facilities, hospital facilities, etc. And there's a minimum standard which all member states have to meet. And the deadline was all member states have to be compliant by 2012. The reality is the majority of member states do not have the minimum core requirements. They've applied for extensions, but the last extension possible expires in July 2016, i.e. this month. And we're still at the point where probably more than half the member states don't have the right capacity in place as they're legally obliged to do. And I think one of our issues to talk about is what has the aid community done in response to that, and have we focused our international aid, our development funds, in helping people achieve that, or have we spent it on other things? There's a requirement for every member state to have what's called a national focal point for IHRs. It's a single office, a person, an email address, a phone number, where anybody who's concerned about a public health event can send the information in. They're in direct contact with the national focal point in WHO and can either share information informally or make a formal report to WHO. And all countries have to have that. But they are at various states of development. They are variously supported within their ministries or not. And for example, I went to South Korea when they had their big MERS outbreak, and among a number of things that went wrong at that point was the national focal point was not sufficiently strong to allow communication of information properly. Within that, there are protocols for deciding how serious something might be. You do a risk assessment. There's a formal chart you go through. If it meets the criteria, you report it to WHO. And WHO's options are to convene an emergency committee and declare a public health emergency of international concern. Once they declare that, then WHO have the legal ability to put in place recommendations on travel and trade and other things, which are then binding on the member states. So they all were meant to be compliant by 2012, very few are. One of the issues was that the primary process for deciding whether a country met the conditions was a voluntary self-assessment by the country. You see, the final endpoint is declaring a FAKE, a public health emergency of international concern. But actually, since IHRs were agreed in 2005, there have only been 4. The first was pandemic flu in 2009. Polio became an international emergency of international concern when it was started, when the decline started to reverse. Ebola became a FAKE, and Zika. Initially, microcephaly was a public health emergency of international concern at a time when it wasn't absolutely clear that Zika caused microcephaly, but as of the last meeting of the emergency committee, it's been changed to say Zika is now the emergency of international concern because they've accepted the link between the two. And one of the issues is that WHO gets about 4,000 to 5,000 events reported every year. So since 2005, there have been some 50,000 events reported to WHO, and they've been filtered down to 4 fakes. And one of the issues we think is that in going from 50-odd thousand to 4, you miss something important. And there's a whole set of issues we can talk about why something becomes a fake or not. So why is Zika and microcephaly a fake? Yellow fever in Angola is not a fake. Ebola was a fake. MERS in Saudi Arabia and the Middle East has never been a fake. So as Richard said, after Ebola they were being revised in 2016. We submitted our report to the World Health Assembly in May. And essentially the key messages we gave back were that the IHRs didn't need changing. What they were set out to do was right. What the problem was, they weren't being implemented properly across enough countries well enough. And they weren't being properly assessed and evaluated. So we recommended moving away from voluntary self-assessment in the country to independent external evaluation. And a process has been developed to do that, but we are now at a stage where a number of influential countries at the World Health Assembly challenge the idea of external assessment. There are a number of countries, you can ask me or I can tell you which ones they are, but they don't like the idea of external assessment. There is also an issue sitting beside that the assessment was linked to the Global Health Security Agenda. The Global Health Security Agenda is seen to be a US-led initiative, and therefore some countries have reacted to the connection with America. But that leaves us in a difficult position where we still haven't got agreement on a formal process whereby we can regularly assess how well countries really are compliant with IHRs, because when you do that, it allows you then to target the countries who need the most support to get to where they have to be. And that's in their interest and in our interest. And that's because we want to look at how we can build health system strengthening into the IHR process and use health system strengthening to help develop core capacities in countries who most need it. That has an immediate benefit for the country in terms of not having the problems that we saw in West Africa, the problem we've seen in Saudi Arabia and in South Korea. Very different countries, but one common aspect of those, apart from the mortality and morbidity, is the economic impact. We know what the economic impact in West Africa from Ebola was. We know there's been quite a big impact on Saudi Arabia, although it's not quantified because we can't get the information. But in South Korea, in the 6 months after MERS hit them with their big outbreak, they lost 0.9% of GDP. Because there were no restriction imposed on travel and trade, but people simply didn't trade with South Korea. And 0.9% may sound small, but I think that's equivalent to about £12 billion worth of coming out of the UK economy if the same thing happened here. So it's important for the country to get this capacity right, and therefore we should do that through health system strengthening. It's important for the rest of the world because we saw the consequences for us of Ebola. We saw the consequences for South Korea from the MERS outbreak, and we're seeing it now from yellow fever in Angola and possibly going into China. But the other reason it's important is to say because we can move from infectious disease to non-communicable disease burdens using the same infrastructure, the same people, the same skills, the same public health systems, allow us to then to move on to look at maternal and child health, to look at non-communicable disease and chronic diseases, to see how can we monitor trends, identify what's changing, why it's changing, and how do we target interventions, how do we select the right populations to target, how do we select the right communities, how do we select the right age group. So by building up public health surveillance, we are putting in place the core capacities that we need for targeting health system development in the future. So some priorities that we could look at. Investing in the core IHR capacity I've talked about, and say they are fundamentally important to the country, they're fundamentally important to global health security, and they are an investment in the future health of a country and the health systems. We need, I think, to encourage and support this independent evaluation because we've seen that self-evaluation doesn't work. One of the interesting discussions at the World Health Assembly came from EMRO, the Eastern Mediterranean region of WHO, who have been enthusiastically adopting external evaluation for a couple of years. They bought into it even before the IHR committee recommended it. And they have said repeatedly in public that they found that the independent external evaluation adds considerable value beyond what they were getting from the self-assessment in country before. And they have now gone out and done, I think it's now 10 countries in the Eastern Mediterranean region have voluntarily asked for an external assessment. And we now have about 40 countries around the world who've requested this joint external evaluation to be done for them, including the United States, whom I went out and assessed 3 weeks ago. And that's an important message, that this is not something rich countries do to poor countries. This is something that's done to every one of the 194 member states across. So if we have things that we can do or money we can invest, we have to look at what's happening in the country first of all and decide where the core problem sits in surveillance terms. Because it might be that they simply haven't got the data that we need. That's unusual, but not impossible. Say, as health systems develop, recording what they do to patients becomes important, so we do have a lot out there. Often it's not been able to share that information. And the sharing is sometimes about the systems and the information technology, but mostly it's about the will to do it. The political will nationally and the local will at health centre or hospital level. People tend to see information as power, and therefore they want to keep it. And they say, we have the information, if you've got a question, come and ask me. That doesn't work for public health surveillance. You have to give the information away to other people. So that encouraging that sharing so that information can be properly used is one area of focus. The next area is whether or not that information can be properly analysed. Have we got the people in the local workforce with the skills who can do the analysis and produce the interpretation of what's happening and alert people? And then there's the internal reporting system, which have we got a means of saying, when people realise this is a problem, how can they alert both national government and international organisations to it happening? And again, that was a clear issue around Ebola. Local communities knew there was a problem for some time. The word was filtering out, but there wasn't a good response and alert system to say to national government, to WHO, to international community, this is becoming so serious, we need a huge investment to solve this Ebola problem. So we need to look at all those potential areas where systems can be weak, or the workforce can be weak, to see what can be developed. There is a thing about IT improvements. There's certainly a need about saying, can we improve IT infrastructure in countries that allows physical information to be shared more easily? But it's also about saying, how can we look at how the world has changed in terms of social media, networking, smartphones, to say, can we use that technology? Clearly there's an issue in some resource-poor countries about how you share big data. But actually, Google does it all the time. Facebook does it. Twitter does it. Now, using those is not easy, but they are a source of information. There are a range now of people who want to develop smartphone apps, and as we know, a lot of resource-poor countries have actually jumped into the smartphone area and bypassed traditional mobile phones, let alone landlines. And that is a technology that's more widely available than people sometimes realise. And it is an opportunity to say, can we look at those to see what can we do to use those as means of collecting information? How can we let a community alert the fact that something strange has happened? And then it's about looking for partners. This is not just about the health system or the human health system. It's also about the animal health system. Therefore, we need to talk to agriculture and farming. There are, in Ebola, good examples of where the extractive industry, the mines, did very good work on their own, first of all in protecting their own workforce, but in using that to expand out and protect communities. But what they didn't have often was the means to share the information they were collecting with the international community. But there are opportunities to use health facilities in mining industries, for example, which are often in remote and vulnerable places, as a means of collecting sentinel information about what's happening in the community around them. And also about communities. We have networks, primary healthcare workers, community health clinics, all of whom have an understanding of what is normal in their community. All of them have the ability to recognize when something unusual happens. What they don't necessarily have is the means to interpret what's happening, or to seek help to interpret what's happening, or to report back up to national authorities that something strange is happening. So it's about how we can work with that community networks we already have to use them again as sentinels and help support them to do the public health surveillance for us. And I think that's all I was going to say. I'm happy to move over and take questions and hopefully have a long discussion.